Well, good morning, everyone. Welcome to the 2018-2019 Neural Prosthesis Seminar Series. I'll introduce our speaker in just a second, but if, as you walked in, you would have noticed these handouts. We now, as of yesterday, have a full slate of speakers for the year. You can see who they are. We have quite a nice set of speakers. So I strongly encourage you to, patronize our series here, and I'm looking forward to a great year. A couple of other announcements about the FES Center. We're having concept reviews on October the 2nd. They'll be over in the Wickenden building in 328. What time? 9 a.m.? 9 o'clock a.m. So if you're a grant submitting kind of person and you have an idea that you'd like to try out on your colleagues, let Cheryl know. These have been extremely effective in the past. You get nice, friendly, tough feedback on your ideas, and it can be a thought. Like, you don't have to have a draft. This could be, I had an idea about doing something, and is it crazy? Okay? That same day at 3 o'clock in the same room, Wickenden 328, people that are new to the FES Center, if you want to understand what we do and what the services are, et cetera, we're having a new member orientation that day. That will come out in an email, right? Okay, so to the main event. So it's my pleasure to introduce Dan Rizzuto as our speaker today. Dan has his own company, Nia Therapeutics, that I think we're going to hear about the technology today. He has, and excuse me for a second. Dan has a BS in biomathematics from Keene State College, a PhD from Brandeis University in neuroscience, and was a postdoctoral fellow at Caltech. He has been worked in the sort of the medical device and medical intervention industry since his postdoc, and he's worked at North Star Neuroscience, for example, Swedish Neuroscience Institute, Varian Medical Systems, the Allen Institute for Brain Science, and just prior to his current company, he worked at the University of Pennsylvania as Director of Cognitive Neuromodulation. And I think you'll talk a little bit more about that today. So please, thank you for coming.
Great. Thank you very much. It's really a pleasure to be here and talk to you guys today. I appreciate the invitation. And I'm very excited to tell you about the technology that we've been developing at the University of Pennsylvania over the past 4 years as part of the DARPA RAM project. RAM stands for Restoring Active Memory. So I'm going to be talking to you today about how you can use electrical stimulation of the brain in an invasive approach to improve human memory. And based on the research and the technology that we developed at Penn, I recently started a company, Nia Therapeutics, that was spun out with the blessing of Penn and DARPA to commercialize the therapies that we've been developing. So, and I'd very much like this to be an interactive type of approach, so don't hold your questions till the end. Feel free to jump in with questions or comments. I'd like this to be as useful to you as it is exciting for me. So this technology that we're developing is really coming out of a long-standing tradition of brain stimulation for motor disorders like Parkinson's disease and essential tremor. Just to gauge where we're at, how many of you are pretty familiar with DBS for Parkinson's disease? Almost everybody. Great. That's wonderful. So DBS for Parkinson's has been approved by the FDA for close to 20 years now. And now it's being used for a bunch of other indications, notably Tourette's syndrome and OCD. There's been some pretty spectacular results from individual patients for these disorders. And then there's some under investigation for other indications, effective indications like major depression. And what I'm going to be telling you today is how you can leverage this technology to go after cognitive indications like traumatic brain injury, memory impairment, and Alzheimer's disease. And this is probably old hat for many of you, but I'll just quickly show the power of this approach in Parkinson's disease. What you're going to see here is a man with Parkinson's disease whose stimulator is turned off, and you'll see his tremors, and then he'll use his patient remote control to turn on the stimulator and show the efficacy of the treatment.
As you can see, the tremors are getting much worse, and I'm in quite a bit of discomfort, and I'm about to drop the remote control, which will be fun because I won't be able to turn my stuff back on. So I think party time is over. Almost automatically. Power comes back on, I'm steady.
So this really shows the power of the approach of brain stimulation to modulate brain activity and deliver therapeutic value and efficacy to patients, really almost in an immediate type of, very much an immediate time scale. So, as I mentioned, we've been building on this technology as part of the DARPA RAM project at the University of Pennsylvania for the past 4 years. And the goal of the DARPA RAM project is to develop novel brain stimulation therapies to treat memory impairment and traumatic brain injury. Of course, TBI is a cause that's near and dear to DARPA's heart, being a military R&D agency with many of our veterans coming back from Iraq and Afghanistan with TBI. So just to level set, TBI is an alteration. This is an NINDS definition for what TBI is. It's an alteration in brain function or other evidence of pathology caused by an external force. Pretty vague general definition. The hallmark symptoms of traumatic brain injury are impairments in memory, attention, and learning. You can have other dysfunctions as well, motor and affective, but the primary symptoms are cognitive, memory, learning, and attention. So in terms of the cause of TBI, in developed countries, motor vehicle collisions are the leading cause of TBI. But you also find, especially in the elderly, you often find that falls are another cause of head injuries. And these are, and there's a really serious global disability burden that's brought about by these injuries. It's estimated that there's between 50 and 60 million new TBI cases each year worldwide. There are currently, today, 5 million, over 5 million Americans that are disabled, have a long-term disability as a result of their traumatic brain injury. And it's estimated by the Penn Center for Brain Injury and Repair that about 30% of these patients with long-term disability have a cognitive and memory disability as a result of their injury. And really, the most striking statistic here is that there are 0 FDA-approved therapies for treating TBI. No pharmacologic interventions, no device interventions. Obviously, this is of great interest. It's under active development by a lot of teams, but right now, it's a really underserved patient population with not a lot of hope for treating their disorder. Yes, please, Andy.
How severe does the injury have to be before it's considered TBI? Like, if you get a concussion on the football field, that is a traumatic brain injury, but I don't feel like it's included in that.
Right. So it turns out that typically they grade TBIs into 3 levels: mild, moderate, and severe. Mild means you've gone to the hospital for a concussion, and they said, just go on home and wait it out. Severe means there was an open head wound, associated with that traumatic brain injury. Moderate means you went to the hospital and they admitted you to the hospital and you had some sort of stay in the hospital, typically overnight. Those are the three gradations. And
all three of those included in the statistics?
So it turns out that disability, you can have a long-term chronic disability as a result of any of those three categories. However, it's only about 10% of the mild cases go on to have a long-term disability, whereas about 90% of the serious and severe cases go on to have a disability, and moderate is probably somewhere in between, around 50% go on. So it really depends, but even with a mild TBI, you can have long-term clinical sequelae from that. It's just a lower probability. And especially with repeated mild, this is why sports is really coming to the forefront of our consciousness right now in sports, is because these soccer players even, right, repeated headings of the ball, they'll have a pattern of mild TBIs over time that can cause significant long-term damage.
How many new cases are a year?
Yeah, so there's about 280,000 clinic visits for TBI in the United States each year, and we estimate. And so that's when that's either moderate or severe, and we anticipate again about a third of those will have a chronic long-term disability as a result. So that's just under 100,000 will become disabled per year. That's new disabled patients per year as a result of traumatic brain injury. So serious disease burden, right? And one that's really in need of new therapeutic alternatives. So as I mentioned, the DARPA RAM project focused on developing new interventions for TBI and memory impairment. What we did was to develop a consortium of medical centers across the United States that are enrolling patients with epilepsy onto our standardized clinical protocols for brain recording and stimulation. And I'll get into and many of you are probably familiar with these ECOG recording studies that are done in patients with epilepsy. And so they're not patients with TBI. Well, that's the clincher of the story at the end that I'll tell you, is that sometimes there are TBI patients in that epilepsy population. But for the most part, we've been focused on studying patients with epilepsy. And we've worked with all of the leading centers, not all of them. There's here in Cleveland we weren't working with. Although I'm happy to report that my business partner, Mike Kahana, is a very proud CASE alum, and he very much wishes he could be here today. But we've been working with Jefferson, Penn, Dartmouth, Columbia, NIH, Mayo, UT Southwestern, and Emory, and of course one of our medical device partners, Medtronic, doing device development work. And I'll tell you more about all of these in a moment. So, as I mentioned, we've been working primarily with patients with epilepsy over the past 4 years, and it's really a unique opportunity to record from intracranially from the human brain and also to administer brain stimulation while these patients are performing memory tasks. So my team has been doing this for close to 20 years. That's where when I did my PhD at Brandeis, we were studying human intracranial correlates of human memory performance. And so this is coming out of a very long-standing research program where we're now leveraging all of our understandings about how the human memory system works, what the intracranial correlates and biomarkers of memory are, and now with DARPA's support, using brain stimulation to modulate human memory performance. So for those of you that aren't familiar with the epilepsy monitoring unit and this type of research study, these are patients with treatment-resistant depression, so that means they're not responding to several drugs, and the seizures are debilitating enough where their electrodes are placed in the brain for the purposes of localizing the epilepsy, and then after 2 to 3 weeks, if they localize the epilepsy, they'll remove that part of the brain that's causing the epilepsy. Now, while they're in the hospital for those 2 to 3 weeks, we'll go in every day and administer memory tasks, record those brain ECOG signals, and then administer brain stimulation in an effort to modulate performance and physiology. Here I'm showing the types of leads that we use as part of this research. You have both depth electrodes shown above and grids shown below. Now, the field as a whole is moving towards depth electrodes because they can be inserted with very small burr holes through the cranium, whereas these grids typically require large craniotomies, which are much riskier. So the risk has greatly come down over the past 10 years as the field has moved to this stereo EEG approach shown above. And you get really widespread coverage in these patients. They'll insert probably sometimes more than 10 of those depth electrodes, sometimes up to 20. So you'll have usually more than 100 contacts per patient in all different locations in the brain. And here's an example of the types of signals that you can record from these ECOG electrodes. ECOG, of course, stands for electrocorticography, and they're really large-scale LFPs, local field potentials. So we're not recording spiking activity, we're recording populations, synchronized neural firing across populations of neurons, probably on the order of tens of thousands of neurons contribute to each of these oscillatory signals. And then we analyze these oscillatory signals using spectral decomposition like wavelets and FFT. So this is very much a big data project. Over the past 4 years, we've enrolled over 300 patients with these intracranial recordings onto our standardized protocols across these 9 centers. We've administered over 1,500 memory testing sessions to these patients, probably closer to 2,000 now. And we've recorded from more than 20,000 contacts across the brains of these more than 300 patients. And what you're seeing in this video is a representation of all of just the cortical contacts across our 300 plus patients. So what you're seeing is we're able to record from really sample widespread brain areas. Each patient, yes, only has about 100 to 150 contacts, but across patients, you can really derive whole brain activity maps during these memory tasks. And of course, we're very much dedicated to an open science philosophy, and all of our data sets can be downloaded for free on our website at Penn with the link below, and I'm happy to share that with anybody who's interested afterward. So how do we assess human memory? The assay that is used, really, it is the most sensitive assay of human memory, is called free recall. And it's used to diagnose memory impairment in patients with Alzheimer's disease, dementia, traumatic brain injury. There's usually a battery of tasks that are used, but free recall is the most sensitive component. And there are 3 phases of the free recall task. Number 1, encoding, distractor, and retrieval. During the encoding phase, so what we do is we place a laptop in front of the patient. During the encoding phase, 12 words are presented one at a time to the patient on the screen. They're instructed to remember those 12 words. Then they perform about 20 seconds of a math distractor task that prevents them from rehearsing the list. It gets rid of that recency effect for those of you who are familiar with this effect in human memory. And then during the retrieval phase, they say as many words as they can remember from that list of 12. And your standard undergrad may remember about 7 or 8 words from a list, but our patients, because their seizures often cause atrophy of medial temporal lobe circuits, they're typically remembering fewer than that, maybe 4 or 5 words per list. That's the average performance in our patient population.
How much time elapses between encoding and retrieval?
The whole thing, one list, takes about 2 minutes. So there's probably 30, maybe a minute and a half. So 30 seconds for encoding, 20 seconds for a distractor, and then 30 seconds for retrieval. So that's one trial, one list. And then we'll repeat that typically 25 times in a session, which takes about 45, 50 minutes. And then we'll do multiple sessions over a patient's stay in the EMU.
Are the words random?
They're random. Well, okay, so we've studied several different memory tasks, from uncategorized word lists to categorized word lists to pairs of words where you have A-B pairs where given A, what's B, or given B, what's A. And we've also tested spatial navigation in 3D environments. I'm going to be focused on the uncategorized word list approach here. They're controlled for concreteness and imageability and their incidence in human language, right? So they're very tightly controlled word pool that are drawn from random each time that a list is shown. But these results, I'll say that we've found that the results transfer across all verbal memory tasks that we've studied, from uncategorized word lists to categorized word lists to pairs of words. But our results have not yet translated to spatial navigation. And happy to dive into that later. Baloo.
Question related. So visual versus audio memory.
Yeah.
And, presumably they have like different circuits which feed into the same network.
Exactly. That's right.
Is there a difference?
So yeah, so the DARPA RAM project has not studied. We've only done visual presentation. What you'll find is that when words are presented visually, the first evoked potentials will be in occipital cortex as it goes through the visual processing stream. When the words are presented auditorily, of course, the first evoked potentials will be found in the auditory cortex. But then after that, because they're all verbal stimuli, they engage the same core memory network, which is really lateral temporal cortex, medial temporal cortex, and prefrontal cortex, with some parietal cortex as well. But there's a core memory circuit, and I'll take you through that circuit in a few, but it just depends on where the information's coming from, visual or auditory.
I don't mean to delay anymore, but these individuals are in the hospital for epilepsy monitoring. Are they on any medication for pain or anything like that that could influence their performance?
Sure. I mean, these patients are typically on a cocktail of drugs, right? So they're on drugs for their epilepsy, even though it's not well controlled by those drugs. In the first few days, they'll also be on, they'll have pain medications as well. So what I want to stress here is that all of the results that I'm going to be presenting to you today are done in a randomized, controlled, and blinded fashion, where we're going to be comparing each patient to their own performance within the same session. So we administer, some lists have stimulation, other lists do not. Within the same session, they're randomized. Patients don't know if a given list has stim or not. They can't feel it or perceive it in any way. And so each patient acts as their own control within a session. So it's very tightly controlled. Okay, great questions. So here's that brain map. This is what it looks like in the brain. It's slowed down. You can see as the green bar scrolls across the screen, word on is where the word comes on the screen. And you'll see activity starting in the occipital cortex, flowing through temporal and frontal cortex during the processing of that word, and then the offset, and then the next word coming on the screen. And this is a representation of high frequency activity, so 80 to 200 hertz activity. And orange indicates an increase in this high frequency activity during the processing of this word. And this activity is correlated with which words are remembered and which words are not. So this is a contrast during encoding of words that are later remembered versus words that are later forgotten. So you can, just by looking in a patient's brain, you can tell if they're going to remember the word that's being presented to them at that moment, just by looking at these patterns of high frequency activation in distributed brain areas. So we believe that this is picking up on a core memory network that is involved in both encoding and retrieval of memory. So what we do in order to predict whether a given word will be remembered or not is to use machine learning. So we'll take our, for each electrode, we'll break it down, we'll break down the ECOG activity from that contact into different frequency bands from 2 to 200 hertz, 8 logarithmically spaced frequency bands. And we'll sort those, the activity from each word into a recalled and a forgotten class. So we've got a 2-class machine learning problem with spectral activity from each electrode that's being used as biomarkers to discriminate between those 2 classes. And we then use logistic regression, a very simple form of machine learning, in order to identify the spectral biomarkers that predict memory performance, that predict whether you're going to remember or forget. We've tried, for those of you who are interested in machine learning and computer science, we've tried a variety of different techniques, from random forest to deep learning, and we found that these techniques really don't do much better. You can maybe eke out 1% or 2% better performance with these more fancier techniques, but logistic regression gets the job done. It's simple, we know what it's doing, so that's our workhorse. So at the output of that logistic regression computation is a number between 0 and 1. And that number represents the confidence that the algorithm has in whether that word is going to be recalled. Essentially, it's predicting which class is the word going to fall into, the remembered class or the forgotten class. And what you're seeing here is from one particular patient that we worked with, and you're seeing 8 lists of 12 words, and you're seeing the time series of that classifier output for each word in each of the 8 lists. And so what you're seeing here is in the first list, the classifier believed all of the numbers are basically below 0.5, so the classifier believed that all of those words were going to be forgotten. And if you look, the blue color code indicates that the patient actually forgot those words, didn't remember any of those words. In contrast, the red color code indicates words that the patient actually recalled. And so what you're seeing is that a preponderance of the remembered words, the classifier had a prediction of above 0.5, meaning that the classifier accurately decoded the words. And same thing on the bottom, for those words where the classifier predicted lower than 0.5, the majority of those words were forgotten. So we're doing a pretty good job at decoding on an item-by-item basis which items will be remembered and which items will be forgotten.
So was this trained on one data set for the participant, or was this like trained on a bunch of data from multiple people?
Great question. Yes, we do completely individual training and classifier development. So it's only trained on brain activity for this particular patient. And this is mainly due to the fact that each patient has a completely different montage of contacts. So that said, what we found is that there is some benefit. You can use what are called priors, Bayesian priors, to do better in some patients. And if a patient has poor classifier performance, you can use Bayesian priors to improve that classifier based on previous patients' brain data. But for patients where you're actually getting good classifiers, the priors don't do very much. Yes?
I asked them to list all the words in order or just all the words in each list?
Yeah, any order. Yep. The instruction is for the patient to remember as many words as they can in any order from the immediately preceding list of 12. Does that make sense?
So along those, so first, presumably this is all cross-validated.
It is very much cross-validated. Great question.
Along those lines, so then the order like the way that this graph shows it, it suggests that, 'cause I'm looking at this and it suggests that the words that were presented first tend to be remembered. Is that a right interpretation, or what is the temporal?
Yeah, that's very insightful comment and observation. You got a good one here. So that's called the primacy effect. And in the study of free recall, there are two effects that are well observed and studied, and that's the primacy, which is the first item or so, maybe first two items have a higher recall than the subsequent items, and then the last few items it's called the recency effect, are also better recalled than the preceding items. The reason we have a distractor task is to bring down that recency effect. So the last items, so other than the primacy, which is like the first item, maybe 1.5 items, there's pretty much equal recall in terms of serial position across the remaining items in the list. But yes, you're picking up on something in that very often the first word, because it's a new context, a new list, is better well remembered than subsequent words.
Because I guess what I'm trying to figure out is that I don't know about what the models of memory are, but it at least suggests that maybe there's a buffer or something that gets filled up, and maybe with TBI or something like that, then maybe the capacity of that buffer is reduced. Is that fair to speculate?
Yeah, the buffer theory of human memory is a very well researched and modeled. It's the Baddeley working memory hypothesis. Yes, there's hypothesized to be a buffer, and this could be a reason why human memory is impaired in certain indications. With TBI, I don't think there's a lot of evidence yet that for exactly where that impairment's coming from, if it is as part of that working memory system. But yeah, it's a great question. Yes.
Does the quality of your classifier, of your machine learning algorithm, depend on spatially where those electrodes are placed in an individual patient, so you get better quality data depending on anatomical regions?
Absolutely, yeah. If you have electrodes in those core regions where I showed in the video, where there's high frequency activation that predicts memory, yeah, you'll get great classifiers. If you have electrodes that are all occipital, right, or all parietal coverage, or motor cortex coverage, your classifiers are going to be pretty poor.
Do you screen patients then based on
No, we take all comers at this point because what we find is we learn something from all patients, and with an IRB approval for 400 patients, we can have that luxury. So yeah, we've been studying all of them, and there have been some happy accidents and findings that we've come to in patients where, we didn't. So when we first started this, we thought medial temporal lobe was going to be the obvious choice to stimulate to improve memory. And what we found, based on some of these patients who didn't have MTL electrodes, we found actually a non-obvious choice for stimulating to improve memory. So this is part of the happy accidents of science.
Are any of the words repeated from list to list? Like one might show up in
None.
the list.
Zero.
And is there any relationship between the words that they can't remember, like they can't remember any words associated with, like, I don't know, buildings or something, or the color red, or like, is there a common associative connection between words that they can't remember?
Not that we've been able to tell. And again, these are very tightly controlled in terms of the uncategorized word lists. They all have very similar properties. Because salience is a big one. If you have a word that's more salient than another word, you're going to be more likely to remember the salient word than the non. And we don't want those types of effects to impact our results.
For the forgotten words, when you're looking at the high frequency data, do you think that the lack of high frequency activity with those words, does that say something about the mechanism by which they're forgotten? Does that mean they're not activating the brain circuit appropriately, or is that like a random chance whether or not they activate that high frequency activity?
That's a great question. What is behind this variability that we're observing? And we find that this is a natural feature of the human memory system. It is never on an even keel. if you think about your own life and your subjective experience of memory, you don't remember everything equally well. There are some things you remember more than others. And some of that is due to salience and other factors, external factors, right? They're either more emotionally meaningful to you, you're more likely to remember your grandfather's face and name rather than what you ate for breakfast a few days ago, for instance. But then there's another source of variability, which is endogenous brain-based variability that cannot be explained by any external factors that predicts what you will remember, and that's what we're picking up on. And we believe that this is the underlying mechanism here is functional connectivity, and the brain is constantly changing its connectivity patterns. And some of those connectivity patterns are more conducive to encoding and retrieving memory, and others are not. And the brain is constantly trying to optimize for what it's doing. And so this is the type of variability that we're picking up on here.
Yeah, I was going to say, let's let the
yeah.
line here.
Let's keep going, because I've got some exciting results to show you. So here's one of the punchlines, is that it turns out that if you use brain stimulation to modulate physiology, the state of the brain matters. So again, each session when we stimulated had Stim and no Stim lists, and this is a randomized, controlled, and blinded design, and we compared for each patient their performance on Stim lists versus non-Stim lists. And it turns out that stimulation improves memory when the brain state is poor, when you don't see this increase in high-frequency activation in temporal and frontal lobes. Conversely, brain stimulation impairs memory when the brain state is good, when you're already predicted to remember the information. So the moral of the story is that when the brain is in an optimal state, you want to leave it alone. It's very difficult to get it to be supra-optimal, right? It's doing its thing. And then conversely, when the brain state is in a poor cognitive state, that's really the prime time to use stimulation to improve memory. So what I'm showing here is across 36 patients. So there's 36 dots on either side. And during a low performance state, we found close to, I think that's it's fairly modest, about a 10-15% increase in memory performance only during those low state words. Conversely, when there was a high performance memory state and you stimulated, we found about a 15 to 20% decrease in memory performance. And this is hiding a lot of variability in that there's variability in brain stimulation location for each of these, right? As well as each dot being a different subject. So there's a lot of variability here. But what this told us is that we needed to develop a closed loop approach to stimulating the brain. You only want to stimulate during these poor performance states, which means you need to record brain activity continuously, diagnose that the brain state, and then deliver stimulation responsively, and that's what we did.
This is a statistically significant difference.
Right.
What is a clinically relevant?
Right.
That's like one word at best out of your list, right?
Absolutely. Great point. And I'm going to put a pin in that, and I'll come back to it in just a few slides when we talk about our TBI data. Yeah, I'll have an answer. So before I get into the closed loop results, I just want to show very quickly that not only are we improving performance, but we're also changing the state of the brain. When you stimulate during these poor performance, poor states, you actually increase the classifier. So the post-stimulation classifier output goes up significantly when you stimulate during these poor states. So we're modulating physiology in really a global fashion, bifocal stimulation, which is an interesting result, and accordingly we're improving memory.
And I might have missed this, but what exactly are you stimulating?
Right, so we use fairly standard stimulation protocols in terms of square wave biphasic stimulation trains. In this study, we were using about 50 hertz. In terms of location, we stimulated, there are many different locations that are shown here. So we're showing that this first publication showed the importance of timing. We hadn't yet honed in on where to stimulate, and that's what I'm going to show you next, is the optimal location to stimulate to to get these effects. So based on that first finding that timing matters, we built a closed-loop system that allowed us to record, diagnose, and stimulate responsively during the performance of these tasks. And in one of these happy accidents that I mentioned, we found that lateral temporal cortex results for one particular patient who didn't have any electrodes in medial temporal lobe. This is the benefit of our approach, having hundreds of patients. We could assess many different brain targets as part of our study. And we were originally focused on medial temporal lobe, which is the logical choice. But what we found was that stimulating MTL was not the optimal. And we found, as one of these happy accidents, that lateral temporal cortex was much more optimal than any other brain location we found. So in this closed-loop study, and this was published earlier this year in Nature Communications, we used machine learning to estimate each patient's brain state in real time, and we only delivered stimulation during the poor memory states, and then we're breaking our results down between patients who are stimulated at lateral temporal cortex versus non-LTC regions. And what we found was that there was an 18% improvement when stimulating lateral temporal cortex during these poor memory states. No, great question. High frequency. So we did some optimization within each patient to evaluate the parameters that were optimal for a given patient. Because we have this biomarker, it's really giving us a true north in terms of how we should be stimulating the brain to improve memory. And what we found was that 100 and 200 hertz were superior to these lower frequencies, like 50 hertz or 25 or 10.
Is this something you turn it on and immediately the memory is better? Or is it something you stimulate, you turn it off, and then there's some carryover?
Great question. What we found, and this is in our, I believe in our current, is this in the current, no, this is in the, it should be in the Nature Communications paper, is that there is a carryover effect of about 1 to 1.5 items. So the item during Stim got the benefit, and then one item post-Stim got a more modest, but also got a benefit. But that's it, right? So it's having a very acute effect of stimulation. 2 items later, which is like, 5, 6 seconds later, you're not seeing any residual effects of Stim. Dawn.
The lateral temporal cortex as your language centers, but only on one half, and it's more prosody on the other side. Did you compare left versus right?
We don't have enough data to compare left versus right. Most of our patients, any patient who had a left LTC contact, we stimulated. There were some where they didn't have a left LTC where we stimulated right, but these results include both right now. But this is a great question, whether language lateralization affects the results, we can't say.
So this is a closed-loop system.
So when are you recording and deciding to stimulate?
During the presentation of the word. So we're only stimulating during encoding. And then, 30, 40 seconds later, they remember.
Make that decision before you turn the stimulation on, though.
Right, so each word is on the screen for about 1,600 milliseconds. We record the first 1,200 to 1,300 milliseconds of activity, and then we make a decision within 100 milliseconds. So it's at the tail end, and we stimulate for 500 milliseconds. So we stimulate at the tail end of the word and maybe 100 to 200 milliseconds after the word. And then there's a 800 millisecond delay before the next word is presented, plus or minus.
So if you present a word that they probably won't remember and you stimulate, they have an extra 20% chance of remembering that word?
For those words that are associated with a low cognitive state, that is, they're predicted to forget those words, if you stimulate those words, they have a 20% higher chance of being remembered than words that are unstimulated in a similar cognitive state. Okay. So now we're going to get back to your question, Dustin. So, this is all great that we have data in epilepsy, right? But how does this translate to patients with traumatic brain injury? And as I mentioned before, TBI or actually I didn't mention this before, but I'll mention it now. TBI is a risk factor for developing epilepsy. So just by chance, some of the patients in our study had history of traumatic brain injury. So we went back, we reviewed the data for those patients with TBI. We focused in on those patients who had lateral temporal cortex stim in a closed loop approach. And what we found, we now have 4 patients. I'm showing 3 of them here because it's pretty late-breaking results. These are as of yet unpublished, so pilot data set. And what we found is that in these patients, we had 2 out of 3 get really great results. 40, 60% improvements in memory performance. One subject didn't get any significant improvement. On average, it's about a 28% boost in memory performance in the TBI population. So we're slowly, from cohort to cohort, improving our ability and optimizing the therapy to go higher and higher in terms of efficacy. And what does this mean clinically? What does a 28% improvement in memory performance mean? Based on the neuropsychological scores of patients with TBI, we believe that this will move 50% of the patients from a disabled to a non-disabled categorization for memory and cognitive impairment. So, depending upon the type of disability, the physician will assess their performance. And so with various neuropsychological tasks, we anticipate that for the TBI patients, 50% would be moved out of the disabled category. So that's one way of thinking about what does this improvement mean to a patient with TBI.
If I could just follow up on that for a second. So this is improvement of a wordless recognition.
Wordless recall.
Sorry.
Yep.
Yeah, not recognition.
Yeah.
Recall. So this is the standard test for the TBI then to decide what level they're in. Is that where this?
Yes, there's California Verbal Learning Task, for instance, is a standard assay for human memory in TBI and Alzheimer's.
So how well does the change in the recall of a word list, right, under a stimulated condition, how is that going to relate to a change in long-term performance, right? So that word list was developed over somebody over a normal condition. That seems to be a good indicator.
Great questions. So now, here's what I do know, which is that the degree of verbal memory, and this is either CVLT or Wechsler memory task, which is really free recall in a standardized neuropsychological format, well-validated tasks. The degree of performance post-TBI on these 2 memory tasks predicts return to work and productivity a year later.
So is that your next set of testing? Because all your tests with stimulation is basically a word recall, right?
That's going to, having return to work as an outcome measure is a very difficult thing to measure, right? So right now we're very much focused on neuropsychological test assays, but that's the promise of this technology. That's going to be much harder to prove, much longer time scales, and probably require additional rehabilitation support in order to help people return to work. But that's the promise of this technology, is to really increase productivity and the need for assistance in this population.
So the risk of taking Bob off a little bit more, just to follow on that. So this is a paradigm. I've taken him off in lots of places already. So this is a paradigm that during the word presentation you give the stimulation, right?
Yes.
So how do you see that meaning when you're going to extend this study beyond just trying to word recall? Does that mean you're going to stimulate continuous? I mean, how does that?
It's a great question. And why don't we put a pin in that and come back to that in a few slides. All right, so now let me show you the RAM technology in actions. Videos speak louder than 1,000 PowerPoint slides. So I'm going to show you one of our patients at the Mayo Clinic who underwent brain stimulation during the performance of these memory tasks. And you're going to see what it's like to take one of these tests and what it's like for this patient to be part of this study. So the first thing that's going to happen, you're going to see 12 words presented one at a time on the screen. There's some annotations here. Words that are in yellow are stimulated. Words that are in white are not stimulated. There is going to be a test. Write them all down. Now he's going to do the math distractor task for 20 seconds. And then he's going to recall as many as he can. Ooh, oh, so sorry about that. He just recalled all 12 words from this 12-item list.
No kidding. All of them.
And this was his comment at the end of the list after he remembered. He had perfect recall of that list. He said, I had a good picture in my head I could just see, right? So he had a very crisp visualization as the words were being presented to him in his mind that allowed him an ability to recall those words at the end of the list.
Yeah, so cloud, sky, plane.
Right. They're related, aren't they? Or are these?
Yeah, this is actually, we encourage our patients. I mean, this is one of the best way to remember. This is there are basic mnemonic strategies like visualizing words together that allow you better recall. So you're absolutely right. And yes, you could say, oh, this is anecdotal, a single list. You know, is this statistically significant? And here is this patient's data. It was published in Brain earlier this year. And we actually did a wash out and wash in this patient as well. So first of all, we did many sessions with this patient. He was outstanding. And we did, obviously there were no Stim sessions, left lateral temporal cortex Stim, and left medial temporal lobe Stim. And what we found was that left lateral temporal cortex was significantly more effective than left MTL and then no Stim. And that left MTL actually had a slight impairment compared to the no Stim condition. And again, if you go to this paper, we show that there was a washout period where we went lateral temporal cortex, MTL, lateral temporal cortex, and we washed out, and then we got the effect again when we went to lateral temporal cortex Stim. So pretty, and again, randomized controlled, yeah, a particular list, you could say, anecdotal, you know, maybe there was something about that list that was easy, but when we have dozens of lists across multiple sessions, I believe this is pretty rigorous.
These lists are generated by psychologists?
Yes. Yep. Yep, the word pool was developed by a psychologist at the University of Pennsylvania, Mike Kahana. All right, so you know, we're winding up the talk here, and I want to just you know, unpin that comment from Dusty a bit ago. And here's the Nia System Concept that we are pursuing for a closed-loop neurostimulation system for traumatic brain injury. And we require a high channel count system. So we are unable to use existing closed-loop systems like the Medtronic RC plus S or PC plus S or the NeuroPace RNS, which only have 4 channels each. We really need to develop our own neurostimulation platform, and that's what we're doing. It has 64 channels, 4 depth electrodes, ECOG depth, 16 channels each for a 64 total channel system with 4 channels of Stim. I've only shown you results from 1 stimulation channel at a time, 1 target at a time. We now have some really interesting results from stimulating 2 targets simultaneously. So we think this is a future area to increase our efficacy even further. We anticipate a cranial implant that does the diagnosis, the sensing of the brain activity, the diagnosing of the brain state, and the selective responsive stimulation. And then because it is a high channel count system, power is at a premium here. You need a rechargeable battery. You could go to chest. Our concept right now is to put it behind the ear, very similarly to a cochlear implant style approach. And the idea, yes, is that when a patient goes home, this system is operating autonomously in the background at all times and transparently to the patient. It's continuously monitoring their brain state and selecting responsively only when needed to improve and change those brain states. There is also a clinician interface and a cloud-based machine learning algorithm that's used to develop the classifier, develop the patient-specific therapy that is used. So you can imagine a patient very similarly to DBS for Parkinson's disease. After implantation, they go into their physician's office, and the physician, rather than assessing their motor symptoms, puts a laptop in front of them, administers memory tasks, and then in the cloud, you're streaming that brain state data and the patient performance data up to the cloud. The cloud uses those machine learning algorithms, identifies the biomarkers, and builds that patient-specific memory model, and then the physician uploads the therapy to the implant, and then the patient goes home and the implant operates autonomously behind the scenes. During waking hours, at night, they take off the earpiece, recharge it on the nightstand. You don't need therapy delivery during the evening or during the shower. So, I think in closing, this is really opening up a new era and a new domain of neuromodulation and applying neuromodulation to cognitive domains. And I've shown you today how memory can be improved and enhanced in human subjects using direct brain stimulation. And I think there's really an opportunity moving forward to go after other cognitive domains like executive function and attention. And with that, thank you very much.
Wow, that's fantastic, Dan. And since I'm up here, I'm signing up first.
All right.
I didn't remember the 12
I've got
words.
a waiting
I'll put
list.
it that way. Maybe it's more attention. Michael.
Thank you. Yeah.
This is we're streaming this, so they can't.
Yeah, really nice work. I guess in what I've observed is executive functioning and motor functioning are somewhat tied, and so in the people that you've tested so far, how long after the injury were they? Were they all sort of in the inpatient still? And do you see any sort of impact on motor function during stimulation?
So we have data from 4 patients with TBI right now. I've shown you 3 of those. They were all multiple years post-injury. And so the injury happened before the acquisition of their epilepsy. We believe in these patients that the injury caused the epilepsy, or that's a likely hypothesis. But none of them had motor impairment as a result of the TBI. It was none of them had a severe TBI. It was either mild or moderate. So some were admitted to the hospital for overnight or a couple of days. But none of them had motor disability at this multi-year time point post-injury.
Well, since you're here.
Here, you also stimulate, I guess, a high frequency, like from 100 to 200 hertz. Okay, so just wondering about the mechanism, the neurophysiology of this thing. When you look at the endogenous activity in the, for example, lateral temporal cortex, do you see high frequency when the word is going to be recalled?
Yes.
In that area?
That's right. That's a biomarker of good memory performance, is that increase in high frequency activity in lateral temporal cortex. Yes. Now, it's not clear to me that stimulating high frequency leads to high frequency, but well, actually, our results suggest that it does, but it's not. Yeah, there could be, yeah. I'm not sure what the mechanism is, but yes, we do see that you see this increase in HFA.
So anytime you're doing long-term chronic kind of stimulation, you're going to be adjusting, overall activity, net activity levels, and likely to be inducing some sort of plasticity.
Yeah.
Are you, before going into long-term, what are you doing to look if this potential plasticity is helpful, so where you don't need this anymore, or potentially harmful, where it kind of renormalizes and then you've just made things worse?
Right. Great questions. So we are about to embark on more chronic stimulation studies in the EMU on the order of 6 to 8 hours, where we'll be using our closed loop systems in really an autonomous fashion outside of the memory tasks and looking at these chronic effects and then administering standardized neuropsychological tests like the CVLT or the WMS. So that's on our radar to do that, to start showing that we can not only show this effect in standardized memory tasks, but that you can use this in a more ecologically valid or chronic type of approach. The other half of your question was, could there be pathological or, suppressive reorganization? And my sense is that with closed loop stimulation, where we're not stimulating continuously, we're stimulating responsively and probably, less than 50% duty cycle, that you're not going to see these long-term plasticity effects that dampen the effect. But that said, if there's always the ability, much like in Parkinson's disease, the patient comes in every 6 months to their neurologist, and the neurologist gives them a tune-up of their stimulation parameters, assesses their symptoms, possibly adjusts the parameters of stimulation. We anticipate a very similar approach for TBI, where every 6 months, the interval is TBD, right? But you can imagine every 6 months the patient comes in to their neurologist's office and to get that tune-up of parameters. But given that it's a closed-loop approach, we think it's much less likely that you're going to have a plasticity-based suppression of the effect, although it's certainly possible.
So my question is this phenomenon generalizable to other tasks beyond recalling list of words? And sort of relatedly, for a clinical implementation, how would that work? Presumably the patient would not want to be sitting around sort of recalling lists of words in their daily life, and also, how could this be applied in a way that is therapeutic and doesn't augment memories that the patient may not want to emphasize, for instance?
So we've studied 4 different tasks as part of the DARPA RAM project. 3 of them were verbal, 1 was spatial navigation. And what we found was that there was really good transfer of capabilities across all of the verbal tasks. You could train a classifier in a uncategorized free recall task and test it in a categorized free recall task or a paired associate task, and it would perform just as well. So where there's really something fundamental about verbal memory that we believe we're enhancing here. That said, there is another type of, well, there's multiple types of memory, spatial navigation, spatial memory being one, and we haven't been able to show any transfer of those models between verbal tasks and spatial tasks. So that's an area that's still under further investigation. So, of course, when you roll this out, you need to ensure that there are no adverse effects. And you could imagine where you could have an increase in verbal memory performance, but a decrease in spatial navigation performance, right? And that would probably not be acceptable. But I think it's also possible that you'll get this increase in verbal memory and have no impact on other domains. So I think that's something that needs to be rigorously studied as we go into our first clinical trial. Was there another component of the question?
Will
What is the clinical paradigm? I mean, this is a take-home device or only to be used in clinic? Or how
no, this is an implantable device, and it's continuously operating when the patient's going about their daily life.
I think that basically by targeting the electrodes specifically enough, you're only going to be listening to verbal memory networks, I mean, essentially.
Well, not only targeting the placement of the electrodes, but our classifier training process ignores all of the signals that are not related to memory. So you put 4 leads in, and then you select only the signals that are related to memory by training the classifier during these memory tasks.
Yeah, you're focusing on that sort of high frequency activity.
In certain areas, that's right.
Great.
Yep. It's really, HFA is a simplification. Really what you see is a tilt in the power spectrum, an increase in high frequencies and a decrease in low frequencies. That's the biomarker of good memory.
So this is DARPA. This is DARPA.
It is DARPA.
Can you comment at all on possible human augmentation or human enhancements? So not for people with TBI, but...
Yeah, I can actually. And I think my sense is that you're really going to need to see a significant decrease in the risk profile of the device before it's able to be used for any sort of healthy human enhancement. But this is, let me be clear, this is the potential of the technology, is you know, healthy human aging is associated with a decrease in memory performance over time. And so this is, ultimately, we believe we have a treatment that can really rehabilitate human aging and cognitive performance due to human aging. But that's going to require a significant reduction in the risk profile. Right now, this type of therapy, and each device, as we talked about last night, has to be evaluated on its particular risks and benefits. And this device, due to the implantable nature and the risks of electrode implantation right now, can only be used in a rehabilitation type of environment for patients who are disabled. But you can imagine, again, as the risks come down, perhaps to the level of rhinoplasty, that senior partners at a law firm will want to have this implanted to outcompete their junior partners. And that healthy elderly will want to use this to, remember the grocery list or whatever. There's lots of opportunities here, but that's further down the road.
I actually just have a quick question, technical, and you may have said it and I forgot. What's the recording rate of this? What's
1
the
kilohertz.
technical? Kilohertz, thanks.
Yeah. Great, well, I'm happy to chat with anybody who's interested. Thank you again very much for the questions.